Hello guys and welcome to my channel. Today we are going to have a discussion on the topic of bronchial asthma. So we will be covering our topic under the following headings. Let us take one heading at a time. So first let us understand what are the various treatment approaches that we have for bronchial asthma. Since we know that the basic problem of bronchial asthma will be bronchoconstriction, so the first thing that we can do is we can have drugs that will mimic the effect of the dilator neurotransmitter, and the drugs that we have are the sympathomimetics. The second is to block the effect of the constrictor neurotransmitter. The drugs that we have are the anticholinergics. Then we can also antagonize the effect of the various released mediators such as the leukotriene antagonist, antihistamines and the PAF antagonist. All these released mediators, they will ultimately cause bronchoconstriction. So we can antagonize their effects. We can suppress the inflammation and bronchial hyperactivity. The drugs that we have, they are the corticosteroids. And next we can also neutralize the effect of the IgE, which is the reagenic antibody, and the drug that we have is the omalizumab. So we have already discussed the pathophysiology of asthma in our previous lectures. If you have not seen it, please feel free to check it out. The link will be given in the description box as well as in the I button above. So let us now have a look at what are the bronchodilators that we can use. So mainly there are three classes of bronchodilators. The first is the beta-2 adrenergic agonist or the sympathomimetics. The next that we have, they are the methylxanthines. Theophylline is an example. And the next group of drugs that we have, they are the anticholinergic drugs, which are the muscarinic receptor antagonists. So before moving on now, let us have a look at what are the drugs that we can use for bronchial asthma. The first group of drugs or the first class of drugs that we can use, they are the bronchodilators. They are very popular in the treatment of bronchial asthma, and today we are going to have a discussion on this topic only. So among the bronchodilators, as we have already said, that there are three classes of drugs: the beta-2 sympathomimetics or the beta-2 agonists, the methylxanthines and the anticholinergics. So in beta-2 agonists, drugs such as salbutamol and terbutaline, they are actually short-acting beta agonists, and drugs such as salmeterol and formoterol, they are actually long-acting beta agonists. You also have methylxanthines, theophylline, aminophylline, hydroxyethyl theophylline, anticholinergics such as ipratropium and tiotropium bromide. Besides these three bronchodilators, other drugs that are used for bronchial asthma are the leukotriene antagonists, montelukast, zafirlukast, mast cell stabilizers such as sodium chromoglycate, ketotifen, corticosteroids, which are given in both the systemic as well as the inhalational form. We mostly prefer the inhalational form. The systemic form is reserved for refractory as well as for more severe cases. In inhalational form, you have got drugs such as beclomethasone, budesonide, fluticasone. In systemic, you have got hydrocortisone, prednisolone, and another novel class of drugs which are the anti-IgE antibody, and the drug that we have are the omalizumab. Let us now have a look at the activity of beta-2 sympathomimetics or the beta-2 agonist. How do they act? Since it is an agonist at the beta-2 receptors, so once this drug occupies the beta-2 receptors, there will be activation of adenylyl cyclase. So because of the activation of this adenylyl cyclase, there will be increase in the amount of intracellular cyclic AMP. This increased cyclic AMP is actually going to activate the protein kinase A. So this is the entire cascade that will be followed. So once protein kinase A has been activated, now it is going to open the calcium activated potassium channels, and because of the activation of this potassium channels, there will be hyperpolarization. Hence, because of this hyperpolarization, the bronchoconstriction that occurred in the patient, now that will be relieved and there will be bronchodilation. Next, it can also causes the decrease in the myosin light chain kinase activity. This myosin light chain kinase, it actually phosphorylates the myosin and activates it, and then there is the formation of the actin and myosin complex, and ultimately there is the contraction of the smooth muscles. But once this myosin light chain kinase activity is reduced, the myosin will not be activated. So if the myosin is not activated, the actin myosin complex will not be formed. Hence this bronchoconstriction will not occur, and there will be bronchodilation, and also increase in the myosin light chain phosphatase enzyme. This myosin light chain phosphatase enzyme, it again helps in the deactivating myosin. So due to these three phenomena, the ultimate result will be there will be bronchodilation in the patient. Let us now have a look at what are the adverse effects associated with the use of beta-2 agonist. The first adverse effect is muscle tremor. Now students, please remember that muscle tremor is the most common adverse effect that is associated with the use of beta-2 agonist. Next we have tachycardia, hypokalemia, restlessness, hypoxemia, and metabolic disturbances such as increase in the free fatty acid, glucose and pyruvate. So now let us discuss about a phenomena that is known as tolerance. So what is tolerance? When we continuously treat a patient with an agonist, then there can be down regulation of the receptor. Because of the down regulation of this receptor in which the agonist was supposed to act, the drug effect now becomes very less. Hence the patient develops a tolerance to the use of these agonists. But please remember a very important concept here, that in case of asthmatic patients, tolerance to the bronchodilator effects are usually not found. In fact, more than 90% of beta-2 receptors may be lost without any loss in the relaxation. And why does this happen? Because of high ADR beta-2 expression in bronchial smooth muscles. This high ADR beta-2 expression, this is the gene that basically controls the beta receptor synthesis. And since this is very highly expressed in bronchial smooth muscle, hence there is a high rate of beta receptor synthesis. Also low GRK2. This GRK2, it actually phosphorylates and inactivates the occupied beta-2 receptors. And since the level of GRK2 is very low in bronchial smooth muscles, hence this inactivation of beta-2 receptors does not occur. But tolerance does develop. This tolerance develops to the non-airway mediated beta-2 responses such as tremor, cardiovascular responses, and to the metabolic responses. So let us now have a discussion on the methylxanthines. Let us see how does the methylxanthine act. So there are two cellular actions which causes bronchodilation. The first one is the inhibition of the phosphodiesterase, which causes the intracellular degradation of cyclic nucleotides. So see students, what happens? This ATP or GTP that we have, in presence of adenylyl cyclase or guanylyl cyclase, is converted into either cyclic AMP or cyclic GMP. This cyclic AMP or cyclic GMP is degraded by the enzyme phosphodiesterase into 5-AMP or 5-GMP. This phosphodiesterase enzyme, it is inhibited by theophylline. So since this enzyme is inhibited, the level of cyclic AMP is going to increase. And because of this increase in the level, this will ultimately lead to bronchodilation. And this second that we have is blockade of these adenosine receptors. These adenosine receptors, they actually cause bronchoconstriction. So once the blockade of the adenosine receptor occurs, it will ultimately lead to bronchodilation. Now let us have a look at the drug adverse effect of theophylline. Nausea, vomiting and headaches. Students, please remember that nausea and vomiting and development of headaches, this is the most common adverse effect that is associated with the use of theophylline. Next, gastric discomfort, diuresis, development of cardiac arrhythmias and epileptic seizures. The development of cardiac arrhythmias and epileptic seizures, this is directly related to the adenosine receptor blockade. The A1 receptor blockade is the one that is responsible for the development of cardiac arrhythmias and epileptic seizures. So what are the factors that affect the clearance of theophylline? The clearance of theophylline is increased in case of enzyme induction, mainly by the CYP1A2 enzyme, and this enzyme induction occurs with the co-administered drugs such as rifampicin and barbiturates. Smoking. Now remember, smoking itself is also an enzyme inducer, and this induces CYP1A2 and actually increases the clearance of theophylline. High protein and low carbohydrate diet, barbecued meat, and in case of children. So the factors that decrease the clearance of theophylline are obviously enzyme inhibition, and these enzyme inhibitors, some of the drugs which act as enzyme inhibitors are erythromycin and ciprofloxacin, congestive cardiac failure, liver disease, pneumonia, viral infection and vaccination, high carbohydrate diet and old age. Let us now have a look at the role of anticholinergics in bronchial asthma. So acetylcholine that acts on the respiratory system, it causes bronchoconstriction and increased tracheobronchial mucus secretion. So if we block the activity of acetylcholine by giving competitive antagonists which are supposed to act at the muscarinic receptor, the M3 receptor, then the effects of bronchoconstriction and tracheobronchial mucus secretion, they will be reversed. So the pathway that we are basically blocking is the M3 receptor. If it was stimulated, then through the GQ type of G protein coupled receptor, it activated phospholipase C, which in turn activated the ionositol triphosphate, and ultimately there would have been increase in the amount of calcium, and this would have caused bronchoconstriction. So if we block this entire pathway, then the bronchoconstriction will be blocked. Let us see what are the various adverse effects that we encounter with the use of this anticholinergics. The most common adverse effect is bitter taste, which specially occurs with the use of inhaled ipratropium. Precipitation of glaucoma can occur in elderly patients, especially with the use of nebulized ipratropium. And this precipitation of glaucoma mainly occurs because of the action of the drug directly on the eye. Hence, to prevent this, we can give nebulization through a mouthpiece rather than a face mask. There have been reports of paradoxical bronchoconstriction with the use of ipratropium, but this paradoxical bronchoconstriction has been found because of the hypnotic nebulizer solution and the presence of antibacterial additives such as benzyl codinium chloride and EDTA. Some of the long-acting anticholinergics, they cause dryness of the mouth. It has been observed in 10 to 15% of the patient, but this adverse effect usually disappears on continued therapy. So that's it for today, guys. Next, we are going to have a discussion on the remaining drugs that are used in asthma and follow it up with a detailed discussion on the GINA guidelines. So if you like this video, then please give it a thumbs up, share it, and comment down below as to what other topics you would like us to discuss. And please subscribe to my channel. So until next time.